Are you incapable of restraining yourself, or do you take pride in being an insufferable know-it-all?
A large man arrives at your hospital. He is carrying a baby. The baby is very sick. This baby will die without your help. Hypovolemic Potter and the Chamber of Shock. I'm Dr. Bhakta. I have credentials.
I can teach you how to bewitch the mind and ensnare the senses, and even put a stopper in death.
Shock is definitely a killer, so let's learn how to recognize it, differentiate it, and stabilize a patient with shock. Patients, unfortunately, do not come to us with diagnoses pinned to their blankets, so we need to be very good at recognizing when a patient might be at risk for shock. The first thing you have to ask yourself when you walk into the room is, does the patient look sick or not? If they're smiling and playful, they are not in shock. Remember, the definition of shock is inadequate oxygen delivery to meet metabolic demands. In short, not enough blood is getting to your brain, and if that's the case, you're not going to be acting normal. So number one, boom, these patients are sick. They've usually had some recent illness or some recent trauma. They might look something like this. You'll be worried, the parents will be worried, and it should get you thinking, this patient needs help soon or they could die. And so that should set off some alarm bells when you walk into a room and see a patient that looks like this, and it should alert you to call a pediatric code blue. Any room in the hospital can become a room of requirement if you call a pediatric code blue.
You found the room of requirement. The room of requirement only appears when a person has real need of it, and is always equipped for the seeker's needs.
Never forget, when you need help in the hospital, to call a pediatric code blue. People will come, they'll bring useful things, and it's great.
Help will always be given at Hogwarts to those who ask for it.
Great, so you've called the code blue, people are on the way, but you still have to figure out what you're going to do with this patient. What do they have? You know that they're sick, but what else is going on? So let's check the vitals. You might think fever and hypotension would be the two things we'd be looking for, but fever is only present in septic shock, so it doesn't necessarily mean the patient's not in shock if they don't have a fever. And hypotension is a very late finding of shock. Kids can compensate for a very long time before they have hypotension, so if you wait to see that before you treat the patient, you could be in very deep doo-doo. However, tachycardia and tachypnea are hallmarks of shock. If you see this in a sick patient, think shock. The lungs are trying to oxygenate the blood as best as they can, and the heart is furiously trying to pump that blood to the end organs. He felt his heart pounding fiercely in his chest. How strange that in his dread of death, it pumped all the harder, valiantly keeping him alive. But it would stop, and soon. No, it won't, because we're going to save him. Okay, so you've noticed your patient's sick, they have a high heart rate, a high respiratory rate, and they just won't be acting right. They might be irritable or hard to arouse. This is because in shock, not enough oxygenated blood is getting to the brain. This makes you act a little bit weird. So your patient's sick, they have a high heart rate, high respiratory rate, they're acting weird, and now you check their cap refill and it's prolonged and their extremities feel a little bit cool. That's a slam dunk. S-H-O-C, shock. You don't even need the K. But just for completeness, K is for kidneys. You'll notice these patients have had low urine output for the past few hours. They're so severely dehydrated that they can't produce urine, and their kidneys are also not getting good blood flow themselves. Sweet, we have a diagnosis, and it's so important, once you make a diagnosis, to shout it out. Make sure everybody in the room knows what we're dealing with.
Everybody!
Awesome, so now we've made a diagnosis of shock. Next, it's very important we differentiate which type of shock we're dealing with, because they all have different treatments.
You need to know what you're up against. You need to be prepared. You need to find another place to put your chewing gum besides the underside of your desk, Mr. Finnegan.
The first type of shock to talk about is hypovolemic shock, by far the most common in pediatrics and fairly easy to understand. Basically, the body does not have enough fluid in the vessels. This can either be the result of poor PO intake or too much output and poor absorption of the GI tract, resulting in lots of diarrhea. Additionally, significant trauma could cause enough blood loss to result in hypovolemic shock as well.
Let's take him to Hagrid.
second type of shock to discuss is distributive shock. In this type of shock, the blood vessels become leaky. Blood flows out of the vessels and intravascular volume is decreased. This is commonly present in sepsis or allergic reactions. So in the body's plumbing system, there's enough water, but leaky pipes are the issue here. And the last type of shock I'd like to cover is cardiogenic shock. Fortunately rare in pediatrics, but if you miss it, it could be devastating for the patient. Here, the body's pump is not working normally, either because of an arrhythmia or a structural abnormality. These three types of shock each have different treatments. For hypovolemic shock, the main issue is there's not enough blood volume. This can be treated by replacing fluids through an IV fluid bolus, or if the patient has a lot of blood loss, through giving them blood.
You have to keep drinking like you said, remember?
In distributive shock, there is enough blood volume, but the blood is leaking out of the vessels. In addition to replacing fluids, treatment is focused on fixing the cause of the leak. Sometimes this requires antibiotics if the cause is septic shock, or it may require antihistamines and epinephrine if the cause is anaphylaxis. In cardiogenic shock, there is enough blood volume and the vessels are not leaky. However, the heart itself is not pumping correctly, either due to an arrhythmia or a structural abnormality. This must be treated with antiarrhythmics, or in the case of structural abnormalities, pressors until the heart can be fixed properly. Excessive fluid boluses should be avoided as not to overload the heart.
For example, oculus reparo. That's better, isn't it?
So as you can see, shock can be very tricky to diagnose, and then, once diagnosed, difficult to differentiate as well. And differentiation is so important because each of the different types of shock have different treatments, and so your history and your exam will be vitally important. Poor PO intake, or vomiting, or diarrhea might lead you toward hypovolemic. A fever might lead you toward septic shock. An exposure might lead you toward anaphylaxis. And a history of a heart condition might lead you toward cardiogenic. Remember to ask good questions and listen carefully. A child's voice, however honest and true, is meaningless to those who have forgotten how to listen. Let's spend the last few minutes of this lecture talking about how to stabilize this very sick patient in shock. You'll arrive in the room with this very sick patient, and you'll have to assess their airway, breathing, and circulation very quickly. It can sometimes be very difficult to assess if a very sick patient is breathing at all and how effective those breaths are being at ventilating and oxygenating the patient.
Dead.
When in doubt, a very effective way to oxygenate a patient is to use a non-rebreather. This way you know exactly what FiO2 the patient is requiring to maintain a good oxygen saturation. If a patient is failing to stay oxygenated on a non-rebreather, they may not be taking effective breaths. In that case, you would escalate to bag mask ventilation. With bag mask ventilation, you are taking over the patient's ventilation for them, so you know they will be taking effective breaths when you see chest rise. Patients who require a prolonged bag mask ventilation will then be intubated to stabilize the airway. In a code situation, while one provider focuses on the airway and breathing, another provider will focus on circulation and obtaining IV access. An IV can be attempted 2 times, and if that fails, an IO should be placed so that life-saving fluids and medications will not be delayed. Once access is obtained, the treatment for hypovolemic and distributive shock is to give a rapid fluid bolus of 0.9 normal saline at 20 mL per kg, ideally over 5 to 10 minutes. Some other medications that may be required in a patient with shock include glucose for hypoglycemia, antibiotics for septic shock, antihistamines or epinephrine for anaphylactic shock, and pressors or antiarrhythmics for cardiogenic shock. In hypovolemic shock, boluses can be repeated until patient is showing signs of stability. And those signs are just a reversal of all the things we talked about before. So their heart rate and respiratory rate will decrease. They will become less obtunded, more alert. Their extremities will become less cool. Their capillary refill will improve, and their lips will become less dry and cracked. And there you have a happy Harry Potter, not a hypovolemic Potter anymore. Congratulations, you have stabilized hypovolemic Potter.
Gryffindor wins the House Cup.